Get started for the day. This discussion is going to go into the topic of neurological systems that you have. This is a critical part of your job that you're going to be dealing with every day, understanding how the neuroanatomy is set up and how the nerves are set up and how everything functions and how we actually suppress it is a very important part of delivering an anesthetic effectively. Basically what we're going to cover is what are the nerves, what are the roles of the different portions of the nerves, and we need you to understand very well the difference between afferent information, which is information that's coming back from sensory information throughout the body, and then how the integrator parts of the brain or the central nervous system takes that information and makes something of it, how it interprets the signals, and then how it then sends out signals to have an effect, which is called the efferent signals. Okay? We actually effectively block almost all those components of the central nervous system with anesthetics. We can be very selective in the sense that we can selectively just knock out afferents, which is like a block, a peripheral nerve block with a certain concentration local anesthetic. Okay? Or we can actually effectively also knock out the efferents and the afferents and leave the integrators alone and have somebody awake with no pain while they're doing an operative procedure and still not be able to move their arm. Okay? So those are things that you'll learn in regional anesthesia next semester. You have to understand the anatomy of the central nervous system and then also go into a lot more detail into the autonomic nervous system. There's different cells in your central nervous system. Specifically, there's neurons and there's structural cells. 50% of the weight of your brain is actually structural cells. And at one time, it was thought that structural cells were just simply structural. They held everything in place. We're actually finding out that it's, of course, a lot more complicated than that. Structural cells are able to not only separate out the actual neurons, which are the ones that do most of the actual thinking in your brain and do the effective work, okay? But it separates out from the bloodstream using the blood-brain barrier, so structural cells are critical for that portion of it. But they're also involved now, they're found to be modulating the actual neurons. So these structural cells also affect the quality of the nerve signal that's generated by the neuron. Now the neuron is actually broken down into several components. Okay, you have to know these components as part of your test. The first component that you have to understand is the dendrite. The dendrite tends to be like the signal portion of that nerve. It's where actually it's sensing other neuron information. Okay? So the dendrites can be one, two, or many, depending on what the cell is doing. The information from the dendrites is basically receiving different signals from different other neurons. And then it integrates that information and sends an electrical signal to the axon hillock right here. Okay? The axon hillock is the area right before the axon. The different integration electrical values that are coming in from different portions of the dendrite, depending on distances and electrical potentials and many factors which we still don't fully understand, eventually summate here. Okay, summate means they add together. If one's coming in out of phase, then the signal goes to zero. If both things are coming in phase together, it excites the cell and sends the neuron signal down the axon. So it depends on the different information that's coming from the dendrites that originates the signal. Okay? Inside the cell, the neuron is just like any other cell. It has all the different organelles that we talked about before. What specializes the neuron in essence is that it still has a nucleus in the actual nuclear body. Okay? And that's an important, very important concept. This is what we would call the gray matter of the brain. Gray matter is where the cell bodies are at. Okay? The reason it's called gray matter is because when you look at it, there's not a lot of fat where cells have that are where the nucleus is at. Versus the white matter is where the myelinated sheaths are at. Okay? Myelin is used by axons and all sorts of nerves to basically insulate the electrical activity. So it acts like a insulator to the axon nerve. Okay? Now, besides the nucleus, you of course have the rest of the mechanisms, the organelles that you normally have in any other cell, which is your sarcoplasmic reticulum, your endoplasmic reticulum, your rough endoplasmic reticulum, your Golgi bodies. All those things are found inside of the neuron as well. And that's also an important thing to know because the neurotransmitters are not originally produced down here, which we'll show you, which are the nerve endings, but actually are here. So the neurotransmitters are produced where the cell body is at and where the actual nucleus is close by. Those vacuoles that contain the neurotransmitter are then transported all the way down to the end of the axon where those neurotransmitters can be released. Okay? So that sounds like an inefficient system, but the efficiency is that the organelles, there's not enough space for the organelles at the end of the nerve endings, so you can't actually have that happen that way. So instead, form follows structure, which means that here's where the metabolic factory is at, so the vacuoles actually have to be transported all the way down for them to be effective. Okay? There's different medications that actually can suppress the neurotransmitter production, and different disease states can do that as well. Or if you cut any of the axons, and as a consequence you get depletion of the neurotransmitter at the end of the nerve terminal, and it's, in essence, basically you have no activity. The actual axon itself, which is what actually conducts the electrical component to the presynaptic nerve terminals, is a very important component of the nerve in the sense that it's taking electrical signals that can transfer very, very quickly from the cell body all the way down to the end of the nerve terminal. Okay? What makes nerves interesting is that they sometimes will convey electrical activity directly from one nerve to the next. But if they want to have differentiation, they send this electrical signal which carries that information very quickly, but the vacuole that's released at the end of the nerve terminal is what actually binds to a receptor and causes the effect that's desired. Okay? So these axons can be unmyelinated. Okay? Unmyelinated axons means that there's no myelin sheath, okay? So there's no covering over the axon. The conduction velocity is, a consequence, a lot slower, but it still gets there. Okay? If it gets too long, then the nerve conduction does not get there in time, and you get this dissipated signal that's really not effective. If you look at a baby when they're born, okay, the human baby consumes most of its fat for the development of the brain. And as a consequence, the myelin sheaths that are for the peripheral nerves are not well developed. And so when you see a baby first come out, they can't really move their legs very effectively. They can move them, but it's very gross. There's no fine motor control. And if you actually were to take samples of the nerves, you would find that it had very low myelin sheath concentration of fat. Okay? Over the next 6 months, the baby drinking breast milk, which has a very high fat content, will begin to deposit fat into the myelin sheaths. And that fat will then allow that kid to develop myelinated fibers that originate from the brain all the way down to their leg muscles, and then they'll be able to walk. That's why it takes longer for a baby to walk than to use their arms. They develop their hand motions because it's a shorter distance between the brain to the hands. Okay. Let's see. What else is important about here? That's pretty much it. Okay. The cells divide in the central nervous system is once the neurons are established, they won't regenerate. Okay. So in other words, when you're born with your brain, you're really not going to increase the total number of neurons after that point. Okay? As you get older, you actually lose more neurons every day. And if you're an alcoholic, you even lose even more. Okay? And we'll talk about that a little later on. But the neurons basically don't regenerate that we know of yet. There's been some very interesting studies really recently where they are trying to cause chemical mediators to cause the cells to regenerate, but that's still not at a very, very experimental stage at this point. The only neuron that actually is able to regenerate, and this is where they're actually coming up with some of these ideas, are the olfactory nerves, which are continuously changing all the time. So the ability to smell is an important part, and it constantly is dividing. Now, there's a different concept that we have that's called plasticity, and this is why a 25-year-old chess master, which has more nerves compared to somebody who's 60 years old, they can play, and the actually 60-year-old a lot of times will win. Even though if you actually do brain studies on these people, the 60-year-old actually has almost a third less brain mass. Okay, so why is it that he's able to compete against a 20-year-old and beat him? Okay, and it has to do with mostly plasticity. How the nerve connections come together is actually very important as to how you actually are able to do something. When you do anesthesia at first, this is a way of understanding plasticity. When you get to clinical, okay, you're going to be all thumbs. You're going to hear something, you're going to be told something, and everything's going to feel like it's going at a light speed. Okay? And you're going to say, I'm never going to get this. Okay? Give yourself about 3 months of total immersion, okay? And pretty soon you'll hear the subtle beep beep from the blood pressure cuff that went off. Okay? You'll hear the ventilator alarm going off. You'll be able to differentiate everything that you need to know in about 3 months. Okay? And the reason you're able to do that is because your brain is plastic. In other words, it has pliability. If you learn something new, it is able to mold to that new thought process, and things that you weren't able to see before all of a sudden become clear. Okay? And that's called plasticity. Now, we use that same thing for treating people with head injuries. We know that somebody who's had a gunshot wound to the head, if they weren't plastic, they would remain, significantly impaired. But if you do repetitive training to somebody for 2 to 3 months, you'll see that they'll get it back. So the brain rewires, in other words. So the brain does have the ability to rewire. The younger you are, the more the ability to rewire. Okay? We had one of my classmates in medical school. This is the first when the MRIs first started, so we were asked to volunteer to go through the MRI tubes. And they did my MRI and said, well, you don't have a brain, John, so you can go on. So I had a normal-looking brain, just according to them. So then they had, one of my other classmates came in, and all of a sudden there was a big ruckus. And we all looked in the scanner, and she had only had one hemisphere. She actually was in medical school with only one hemisphere, and she'd been that way mostly all her life. Okay? So, just because you have significant deficits at birth doesn't mean that the brain can't change significantly. Okay? So the same thing, that's the concept of plasticity. The cell body, which is the soma, is located, these are small words that mean a lot. Okay? So the cell body, or soma, okay, soma in Latin means body, is located mainly in the central nervous system. Okay? This is the portion of the cell that has all the energetics, all the capability of doing work. Okay? Without this portion, the rest of the nerve dies. Okay? So the body wants to protect these very valuable nerves at all costs, and encases them in skull and basically bone. Okay? So the central nervous system is where most of our cell bodies are located at, including our spinal cord. So most of these very valuable nerves are protected by very high-density bone. When they're located in the central nervous system and packed in cell bodies, they're called nuclei. And I wish somebody had pointed this out when I first started. It would have made things, understanding neuroanatomy, so much easier. Okay, so I'm trying to point this out to you early. Okay? So densely packed cell bodies in the central nervous system are called nuclei. The same nuclei that you would have centrally, when you go peripherally, they're called ganglia. Okay? But it's just a cell body. Okay? So sometimes you go from cell to cell. Okay, and the cell body is the next one, which has got dendrites that are accepting the information. Now, dendrites are the receptive portion of the neuron, which I showed you before. The axons actually carry the nerve impulses away from the cell body. It's a one-directional impulse. The axon hillock is the area where you actually take the information coming in from the dendrites and then decides if you should send the signal down the axon or not. It's a Nissl-free body, and the reason it has to be Nissl-free body, if you think about it from the electrical component, if you have a bunch of organelles in the way, it will actually alter the electrical quality that arrives, and as a consequence, you don't want to have anything there. And you want to have sort of just free cytoplasm, so if the waveforms that are coming in it will actually give you the best signal to basically propagate or not to propagate based on that signal. The initial segment of the axon is the area of the axon having the lowest threshold for stimulation, so action potentials basically begin at this point. Okay? So this is where the actual action potentials are generated and started and then transferred along. Now you see on this picture that you see that there's little like white indentations here. Okay? Okay, those are called the nodes or NVA. Okay, the nodes or NVA are locations with high density of sodium channels. In between these 2 points, okay, is myelinated sheath, which doesn't have any sodium channels in it. What the axon's doing is effectively using high concentrations in small areas of sodium channels to propagate the signal by opening the sodium channels. That causes the inside the cell to become positive, and as a consequence propagates electrical signal along the axon. It's called saltatory conduction because it's like it jumps from one of these nodes or NVA to the next. Now the clinical implications of it is what? Well, the clinical implications are that if you want to block out a nerve signal, okay, if you want to shut down that nerve so it does not transfer electrical activity anymore, you have to knock out 3 nodes or NVA. Okay? If you only block out one, the signal will actually pass by and go to the next node or NVA and get propagation and still get the effect. If you get 2 nodes or NVA, then you get this diffuse sort of partial signal that maybe or maybe not. But if you knock out all 3, you get no more propagation. So it's another way of understanding why we have to give volume when we do a lot of our peripheral nerve blocks. The peripheral nerve blocks, because the node or NVA can be fairly farther apart, require more volume. Okay? Versus if you do a spinal or something that takes very little volume, because at that point the nodes or NVA are not what you're blocking. You're actually blocking either cell bodies or affecting right here at the axon hillock. The accessories to the nerves, besides the actual nerves themselves, you have the endoneurium, which is a delicate layer of connective tissue around each axon. This tries to help maintain the integrity of the cell. Then you have the neurolemma, which is a thin membrane between the myelin sheath and the endoneurium. And then you have the myelin, of course, which is a segmented layer of lipid material that insulates and keeps the loss of the electrical signal from taking place. Now, myelin formation is not formed by the neuron. Okay? It is formed by a structural cell. Okay? If we look at it from the standpoint of peripherally, okay, that cell is called the Schwann cell. If we're looking at it from inside the central nervous system, sometimes you'll hear the terminology Schwann cell, or also things that produce also myelinated sheath are astrocytes, okay, which are structural cells in the central nervous system. You can see how pretty this is. This actually shows you this layering effect of lipid bilayers on top of this, which myelinates and insulates the nerve axon. And you can see the nodes of NVA actually allows it to exposure from the outside environment all the way down to the axon surface, where the sodium concentrations, sodium channels are very high concentrations. What's important about this is that this is lipid, okay, and the lipids is white. And that's why when you do a anatomical study of the brain and you do start doing cut sections, you'll see that the gray matter is on the outside and the white matter is on the inside of the brain, because that's sending axons inwards. Okay, so it has to be white on the inside. It has to be the myelinated fibers going down towards the spinal cord. The neuron communication is going to occur by different methods. You can do it by divergence, which these are concepts right now, so don't be worried about. I'm not going to tend not to ask this for exams, because this is way above even my level of understanding and most people's understanding, I think. The brain is actually a very complicated computer. It's not. Our computers are actually very simple. Okay, if you look at our Macs or our Windows machines, they're only based on 0 and 1. That's it. So it's a binary system. All the stuff that you type in is based on a binary code. The brain is not a binary code. Okay, it's actually a much higher level of encoding than that. We think it's a quaternary code, which is a 4-base code, is what some people are saying, which means that we're about the rate we're going. So what I heard was that we were about another 100 years of computer before it actually gets to be able to be alive. Because by that point it'll be very close to a brain, human brain. But so just something to think about. Divergence is the ability for the actual branching axons to influence many different neurons. So in other words, the signal is diverted into many neurons. Okay? Or convergence means that you're taking lots of different information and you're converging it to one neuron. And so the brain has the capacity of doing both. Okay? This shows you how it actually has information. You get input of information, and then it goes output. And there's actually inhibitory signals that are sent back to the neuron as well. And these things can actually feed back on this to suppress the nerve, or sometimes may actually re-stimulate to cause a hyperaccentuation of the nerve signal propagation. Okay? You can see this. This is right here. This one example in A is a example of convergence. Okay? And this one is an example of divergence, where you're going from one presynaptic axon, one axon to two axons. To show you how complicated this whole thing is, what they've done is they've put in different kinds of electrodes in here to measure the actual electrical potential coming in from different dendrites. Okay? And eventually what you see is either a summation event taking place, which is what you see in this example. And a summation event basically then causes a propagation of nerve signal downstream. Or you can actually get a situation where you have an excitatory and inhibitory from different dendrites coming in. And the answer is either you're going to get a positive effect, a temporal summation excitation, or you're going to actually get an inhibitory effect, depending on what the dendrites are coming in with different forms of information. Now, let's get to what we do, classification structurally. Okay? Structural classification can be based on just looking at it under microscopy. Again, this is something we tend not to do in clinical. We don't do brain biopsies on people and just evaluate them. Instead, what we use is what's called a functional classification. So structural classification is just fine. It gives you basically how the actual thing looks like under microscopy. But really what we use clinically is functional classification of neurons. And that's where you need to be, that's where you can get tested on as well. What we do is we break it down into three major components. Okay? One is sensory, okay, which is the information that's transmitted, impulses from sensory receptors throughout the skin and throughout the body to the central nervous system. This is usually via afferents, okay? And that could be pain, temperature, okay? It could be light touch. It could also be proprioception, which means that you know exactly where a portion of your body is at based on space. Okay? You can also have the next set of functional classifications, associational, which is transmitting impulses from neuron to neuron. And there's also the motor, which transmits impulses from the central nervous system to effector organs. And that could be all the way from skeletal muscle to a certain degree of breaking it down further into autonomics, which are the smooth muscle function of different either intestines, heart himself, or cardiac muscle. So we actually have also another system besides that. Okay? The structural cells in your body can be broken down into what's called the neuroglia, which are the nerve glue. It makes up about 50% of the total brain volume, so it's a pretty big amount of the brain. There's different forms of neuroglia. The astrocytes are by far the ones that we talk about considerably all the time, which comprises the blood-brain barrier. The astrocytes are very important in the sense that they actually completely cover all the capillaries that are coming into your brain. Every single capillary that's coming into your brain is surrounded by these astrocytes. And they form basically an effective one additional layer so that capillary material cannot transfer directly into the rest of the brain cells. The astrocytes literally pick out what they want to allow to come across. And that's really good for the brain because if you don't have an intact blood-brain barrier, which means you have a disruption of the astrocyte function, then you get toxins that are reach into the neurons, and you can get convulsions, encephalopathy, excitation, you get all sorts of problems. So these astrocytes are critical in maintaining this very tight blood-brain barrier. And I'll show you some pictures of them in a second. The oligodendroglia, also called the oligodendrocytes, make the actual myelin in the central nervous system. Okay, sorry, it wasn't astrocytes, the oligodendrocytes, which are also the Schwann cells. Okay, the microglia are basically like macrophages in the rest of the body, which actually remove debris. And then you have ependymal cells, which are extremely important because they line where the cerebral spinal fluid is actually formed and help eventually form the CSF as well as removing it indirectly. This is a nice picture because it shows you what the blood-brain barrier is. I just found this the other day. Somebody sent me this in my email. And this shows you a nice picture of how the astrocytes, how they're actually completely surrounding the capillaries. And you can see these are tight junction cells, which means they're opposing each other and touching this cell surface to cell surface. And that makes for a very tight blood-brain barrier. Okay? This is very unique. There's no other portion of your body where that occurs, where you have individual cells completely surrounding the structure. This is the only place that it takes place is actually in the brain. Structural cells also have other effects, as we found recently. They actually are now being found to actually take information and process it and basically affect the actual nerve transduction that's taking place. So again, it adds one more layer of complexity that we didn't know existed. If you'd asked me this 30 years ago or 20 years ago when I first started, we didn't know anything about this, so this is rather new as well. Microglia are kind of interesting little suckers. Okay? They're basically these little guys that are sort of sitting in your brain. Okay? And when they get activated, you can get things that will activate will be like viruses, when you have destruction of brain cells, where you have CNS toxins taking place, damaged neurons, ischemia. Eventually leads to an activation of these microglia. The microglia then change and become basically like macrophages. Okay? So they've actually changed their configuration from just being sort of having sensory arms sort of sitting around doing nothing, and then it waits for the activation, and then it converts into like an amoeba. And then it goes around and eats whatever is bad around in that area. Okay? And that causes cellular destruction of the brain. Okay? One of the things that can activate the microglia in a very negative fashion will be actual iron, ferritin. Okay? So when you bleed into your brain, that's really not a good thing. Okay? Because it's not like bleeding underneath your arm where you just reabsorb the blood in a few days, not a big deal. If you bleed into your brain, the ferritin activates the microglia, which then causes the microglia to eat the surrounding brain tissue, even though it's normal. Not good. So you can get extensive damage from that. Okay. These are our little amoeboid friend here. Then he forms into the phagocytic microglia, which it begins to eat whatever it encounters. And as it goes back to its activated state of time.
So is it break because apparently it's still lying around the tissue?
It's actually a very complex three-step process. Ferritin, which is Fe, conversion of ferrous to ferritin, which is Fe3+, causes oxidation to take place, okay, and the formation of oxygen and free radicals. Those oxygen-free radicals are very toxic to the brain, okay, and it also activates the microglia, which then, besides the actual ferritin causing destruction of cells from the oxidation effects, but it also activates the microglia and it adds up to the damage on top of that. So, yeah, it's a complex mechanism, but it's not good. So you don't want to bleed into your brain. Neurons basically generate and conduct communications via two ways. They do it by electrical signals, and the other portion is a chemical component of it. Okay? The electrical component is very important because it propagates nerve signals quickly and unidirectionally. Okay? But it doesn't have any specificity. If I connected up one nerve to another nerve, the only thing that would you be able to change would be the actual frequency or be able to change the amplitude of this nerve signal. But instead, by having you propagate the nerve signal and then going to an area called the presynaptic terminal, the actual vacuoles that I have there, I can change, and the neurotransmitter. And the actual end effect will be very different, depending on the receptors that I have on the other side of it. So that makes it more selective. Okay? So the second portion of the nerve, which is at the presynaptic nerve terminal, is the actual chemical impulses that actually release these neurotransmitters that affect other nerves nearby. Axons can actually be bundled together, okay, in peripheral nervous system, and when you do that, you call them the nerves. Okay? When you look at a nerve in the arm, okay, let's say the brachial plexus, the information that's coming back and going down the arm is bundled together. Okay? So when you're doing an individual nerve block, you're blocking both the afferent information as well as the efferent information as well as the sympathetic and parasympathetic fibers that are going out along with it. All the stuff gets covered and put together as a package deal. That makes sense, okay? If you just think about it, okay? If you have to run a bunch of wire through a wall from one point to another point, you're not going to put the wire in 5 different portions of the wall. Okay, you're going to put it all sorted together and then push it through one hole. Okay, you wouldn't want to create 5 different holes for 5 different portions of the nerves. Okay, so when you do a peripheral nerve block, you tend to have the effect of knocking out everything at once. Okay, both the afferents and the efferents and the autonomics. Okay? The axons are bundled together in the central nervous system, but they're a little bit separated out a little bit more because they're following their different tracks as they're going down. Okay, but what's really important for you to understand is that when you put things together, they're no longer called now, they're not nuclei anymore. Nuclei is where the cell bodies are at. When you're looking at the actual where the axons are traveling, which is where the electrical signal is going through, when you first start neuroanatomy, you get lost because they start going into saying words like it's a track, it's a lemniscus, it's a peduncle, or it's a lemniscus or a fasciculus. Okay? All that means is that's where the axons are traveling. Okay? I wish they would just say, okay, why don't we just say this is the substantia nigra is actually where the nerves are at, nerve bodies are at, and then you can say the I'm trying to think of one. Lateral tracts, okay, or medial tracts. We could say just say medial or lateral axons. Okay? We don't do that. Instead, the terminology gets very confusing, and they use 4 different things to basically mean the same thing, which is axons. Okay? So anytime you read in the textbook and it says tracts, fasciculus, lemniscus, or peduncle, they're talking about axons that are traveling through the central nervous system. And that's really important because when you start reading these texts in neuroanatomy, you'll get lost if you don't get that basic concept. Okay? You'll think, like, is that a cell body? No, it's just a tract. It means it's going from one point to another point. Okay? Basically, nerves transmit the information via electrical and chemical. Okay? The electrical basically transfers from the axon hillock all the way down the axon, where then it releases a neurotransmitter, which is a chemical mediator, to the next nerve. You can also have situations where the axon, like the alpha motor neuron, which is located in your spinal cord, sends the signal directly all the way out through your nerve, okay, all the way down to your leg, let's say, and binds to your muscle at what's called the neuromuscular junction. Okay? That neuromuscular junction then releases a neurotransmitter as well, which we call acetylcholine. All muscle in your body pretty much is controlled by acetylcholine. Okay? Pretty much all your skeletal muscle is controlled by acetylcholine receptors. And that's important because when we talk about neuromuscular blockers, such as vecuronium, pabulon, atracurium, all those drugs, they all basically inhibit the binding of acetylcholine onto those receptors. The synapse is the region between adjacent neurons. Okay, that's where you actually get the chemical signal, which is a neurotransmitter. The actual impulses are transmitted across the synapse by chemical and sometimes by electrical conduction. But most of the time when we're talking about this, we're talking about mostly as chemical. When you're talking about in the brain itself, you may actually have direct contact between one nerve to the next, and you may get electrical transduction taking place, like pacemaker cells work that way via gap junctions. They don't really work by neurotransmitters that much. But instead, when you're talking about most things like muscle, skeletal muscle, and then you're talking about a neurotransmitter. You can break these down into presynaptic neurons and postsynaptic neurons. Okay? And that specifically becomes very important when we start talking about autonomics, and I'll get back to that in a minute. The connections between pre- and postsynaptic neurons can be going axon to axon. It can be axon to soma, which means a cell body, axon to dendritic, or dendritic to dendritic. So it's a very complex mechanism that we have actually in our brain. Now what we're going to do is we're going to keep it simple in the sense that try to get it so you understand the concepts first, and then we'll move on to adding more detail as we go along. What's usually made as a typical example of a synapse is the binding of acetylcholine receptors, usually either at the skeletal muscle or in the central nervous system layer. We'll use skeletal muscle as an example for now. Okay? So imagine the connection between your alpha motor neuron, which is a neuron that originates from the anterior portion of the spinal cord, going down towards your leg, say your thigh muscles. Okay? Once it arrives there, the nerve actually will bind to the actual muscle itself, and at the actual receptor site there will be actually the slight difference in, it won't be a direct contact, but there's a slight separation which we call the synaptic cleft. In that synaptic cleft we have an ability to float neurotransmitters from one side to the other. It's not air, it's actually liquid. Okay, so a synaptic cleft is water in between these two layers. Okay, salt water specifically. And what you'll have at that point is when the neurotransmitter, when the axon comes in and depolarizes, okay, it will cause calcium to be uptaken, and then that calcium will help bind the vesicle which has the neurotransmitter, which in this case is acetylcholine, and then the acetylcholine will be released into the synaptic cleft, which then binds to the acetylcholine receptor and causes the muscle to contract. Okay? Now, the acetylcholine is broken down by an enzyme, which we call acetylcholinesterase, into two components called acetate and choline, and that makes it inactive and stops the actual action from reactivating. Now, so here's what the actual events that take place. I'm going to sort of read it to you first, and I'll show you a picture again. Okay? And this is all going to be part of your exams, and this is things you have to know, because everything that we do in anesthesia, okay, when we're talking about local anesthetic action, spinal anesthetic action, even the effects of a lot of our general anesthetics will actually inhibit some of this activity. Anyways, electrical activation from an axon basically reaches the presynaptic area. This then causes the release of neurotransmitter into the synaptic cleft. The synaptic cleft allows for only one-way information to take place, and the chemicals must span the distance and bind to the receptors. Now, when you go back and look at this picture, you think, oh my goodness, that's a huge distance. But when you actually look at it from the microscopic level, it's a really small distance, okay? And it's actually very efficient for this chemical to come across, okay? It's very quick. The diffusion of the neurotransmitter then occurs to bind to a postsynaptic membrane or postsynaptic receptor. So it doesn't bind directly to a membrane, but actually binds directly to a receptor, which is a protein. Okay? This causes an activation or an inhibitory effect, depending on which neurotransmitter we're talking about. Eventually, there's a dissociation of the neurotransmitter from the receptor, and you can actually get reactivation if that neurotransmitter is not, shut down somehow. The most common way that you have is either two ways. You have one mechanism that's like acetylcholine. We have a specialized enzyme that breaks down acetylcholine right away. Okay? Or you have an uptake mechanism by the cell that pulls back the neurotransmitter, like MOA, and monoamine oxidase pulls back a norepinephrine out of the actual nerve terminal back into the presynaptic terminal. Okay? Also does COMT as well. Anyways, you also have, you eventually get either breakdown or reuptake, okay, and then you get passive diffusion. And then you don't want to waste the neurotransmitter because it's valuable. It's a chemical modality that you do need. So a lot of times the cell will reuptake it or use portions of it and reuse it then. Okay? Now, so this is the same thing that I just wrote, but now it's in a graphical format. And I'm going to add a little more detail. Okay? As your nerve impulse is generating a positive stimulus, okay, inside the cell, it's actually altering the voltage inside the cell of the axon. Okay? When it reaches the presynaptic terminal, okay, that general area is maybe minus 60 or minus 70 for most axons. So when the propagation comes in here, it changes the voltage from minus 70 to plus 10 and goes back to 0. Okay, so it's positive then. Okay? And as a consequence of that, you cause a voltage-gated channel to open. And that voltage-gated channel is calcium. Okay? Calcium is what actually initiates the microvesicle movement. Okay? So if you have somebody with very low calcium levels, okay, guess what happens in neurotransmitter release? It becomes inhibited. Okay? And that's important, again, because if you're having somebody who's in the operating room and you're seeing them hemorrhaging a lot and you're giving a lot of citrate in your blood products, you may actually start binding all the extracellular ionized calcium, and now when the nerve terminals want to send, let's say, an norepinephrine release to cause the vasopressor effects to take place, you get no effect because you're not getting any ionized calcium coming in. Okay? So you need to give that person calcium, so now then you get the nerve propagation. Anyways, let's move on. Why would calcium be so important, right? Why is it that calcium does what it does? And the answer is that it's a divalent cation, and what it does is it binds to a microtubular network. It doesn't bind to the actual vesicles themselves, but actually is like an energy source for the microtubules to actually change their configuration, and it ratchets the vesicle towards the plasma membrane, and then basically it causes exocytosis to take place and releases a neurotransmitter. So calcium is very important for that mechanism to take place. Now calcium, of course, is going to be immediately taken out of the system as quickly as possible because then it becomes toxic to the cell. So this mechanism, not only does it bind calcium in, eventually over a very quick time the voltage gate closes back up, calcium is shut down from coming in, but then it's pumped back out immediately. Okay? So it tries to recycle the calcium constantly in this environment. Okay? Once the, yes? Muscle's a little bit more involved in that. I'm just showing you right now the presynaptic involvement. Okay? When you're talking about muscle, what happens first is that when the acetylcholine binds to the protein receptor, it causes a configurational change. The sodium channel opens up, and the sodium then pours into the muscle cell itself. Okay? Once the sodium pours into the cell, it changes the voltage inside the skeletal muscle. Okay? Once it changes that skeletal muscle voltage, it also then causes calcium channels, voltage-gated calcium channels to open. Okay? Those are located in the sarcoplasmic reticulum of the muscle, okay? Where very high concentrations of calcium are inside there. Okay? Calcium then pours out of these SR mechanisms, as well as calcium from the extracellular space pours in, okay? Which then is used to bind to the tropomyosin complex, which then allows for actin and myosin to bind and cause the contraction to take place. So calcium is really the one that's important for muscle contraction. But what actually initiates the calcium release is the acetylcholine signal, which causes the sodium to let the influx taking place. The actual acetylcholine receptor does not cause direct action. It's indirect in the sense that it's not the main sodium is not causing the muscle to contract. It's calcium that's released afterwards. Okay. Does that make more sense?
So we're waiting for a muscle to contract, or we're waiting more for that process of the muscle to...
You need the calcium. Yeah, you need the calcium. Without the calcium, it won't contract. So once you contract, what terminates the signal is the reuptake of calcium. Okay. The neurotransmitter then travels across the synapse. Okay, then binds to the receptor. If it binds to the receptor, then activates and causes a conformational change on that receptor and allows, in this case, for the muscle that we're talking about, sodium to cross over, and then it causes voltage-gated channels inside that muscle to take effect. You can see the neurotransmitter is then broken apart by acetylcholine esterase, which breaks it down to acetate and choline. Acetate usually diffuses out, but choline is reuptaken and reused. Okay? And then you can reprocess the material. Okay, what's really cool about the central nervous system is there's many different neurotransmitters. Okay, and that's what makes us really unique. Okay, human beings have an excess of 30 of these neurotransmitter substances, and I think they're much higher than that. I think we haven't found them all yet. Okay, but the ones that we do know pretty well are the excitatory ones. Okay, such as these excite postsynaptic potentials, such as acetylcholine, norepinephrine, glutamate. Substance P is also a very exciting excitatory mechanism, which is caused by pain. That's why it's called substance P, because it's associated with pain. On the other hand, you have inhibitory systems that suppress the signals. Okay? And that's equally important. Okay? The typical example of a lack of an inhibitory neurotransmitter in the disease process would be Parkinson's. Okay? Parkinson's, you see, when somebody puts out their hands in Parkinson's, you'll see that their hands will flutter. Okay? Same thing, if you look at a baby and you tell the baby, say just play with the baby, have their hands put up, you never see a baby go looking up and keep his hands steady. He's doing this right away. Okay? So he looks very similar to a 75-year-old, which is doing the same thing. Okay? The reason that the person is doing that is that both their dopaminergic systems are not well founded at that point. A baby very soon will connect up to the axons that are becoming myelinated and basically modulate the signal that's coming from the brain cortex that sends the efferent out. And as it sends the signal down the brainstem, you have a modulating system by the cerebellum which tells you where your hand's at, and it stops the noise. It makes your hand flat. Okay? The nerve signal that originates from the brain is so coarse that it makes you have up and down movements, but the cerebellum micromanages it the last second by sending inhibitory signals to the substantia nigra, and it causes this modulation to stop. Okay? So in Parkinson's disease, you have a lack of cell production of dopamine. Okay? So if you don't produce the dopamine neurotransmitters, then you don't get that inhibitory effect and you get that gross abnormality of your function. Okay? Now, the other very important inhibitory receptor that we use a lot of is GABA. Okay? GABA receptors are agonists that are inhibitory. So propofol is a GABA agonist. Versed, or benzodiazepines, are GABA agonists. Okay? Barbiturates are also GABA agonists. Do not write antagonist. Okay? They're not antagonizing. They're acting like an inhibitor. Okay? What you're doing is you're giving a greater supply of a GABA-like substance to cause inhibition and brain suppression. Okay? Very different. They'll catch you that on your exams, which means I'll try to catch you on that exam as well. Okay? Make sure you already have that one now if you know that. Okay? The other ones that are also inhibitory are serotonin, which are very important for sleep as well. Okay? You also have endorphins. Endorphins are one of those things that without we would have a hard time surviving. Endorphins basically take away pain in certain situations. Endorphins can also be a very important part for many people's lives. It actually drives many people to look for excitement, okay, as the endorphins are released in the body during high levels of stress. Okay? If you're an epinephrine junkie, what you really are is you're an endorphin junkie. Okay? If you like trauma and seeing blood squirting everywhere and you think that's the best thing in life, you're an epinephrine junkie. You'll be hooked on that. What you've done is instead of using drugs or something like that, you found a job where you can have that high, and that's okay. Okay? That's why surgeons do what they do as well. And then you have enkephalins, which also have inhibitory effects as well. Okay? We'll stop here, give you guys 10 minutes, and start back up at 9 o'clock.